outset, I would like to thank Professor Krishnamurthy from India and Dr. Aotorpulmonary from Bangkok for giving me valuable inputs before proceeding with this case. And I'll be sharing a case of transcatheter closure of distal AP window with you. So we have a 5-month-old baby with history of poor weight gain and fast breathing since birth. And on examination, the child was slightly tachycardic and had good pounding pulses and well-felt femorals, and saturation was normal. The apex was slightly shifted down and out, and there was a grade 3 continuous murmur held at the left second intercostal space. There was no obvious dysmorphism, and there was a mild developmental delay as per history. And going on the chest X-ray, there was cardiomegaly with increased pulmonary blood flow, and this is what we found on echo. So we found the defect above the level of the pulmonary valve, and it's almost at the level of bifurcation of the pulmonary artery, close to the origin of the right pulmonary artery. And we measured this defect to be between 3.2 and 4 millimeters by echo. And going by the Mori classification, this would fit into type 2 distal defect, where there was a good rim of tissue between the semilunar valves and a restrictive defect, whereas type 1 and 3 are almost flush to the level of the semilunar valves. We don't have enough rim for the device to be held in place, and type 3 being massive again is not amenable to transcatheter therapy. And coming on to how this defect looks from some of the autopsy pictures, we have this main pulmonary artery split open over here, and excuse me. The main pulmonary artery split open here. We find the aortopulmonary window right here, and in this we are able to see the origin of the left pulmonary artery over here and the proximity of the right pulmonary artery to the defect, and this explains very clearly why there might be impingement of the right pulmonary artery when you're going to be devising this kind of a defect. And here are more echo pictures and the homework that we did before we went on to close this defect in the cath lab. So the measurements, and this is around 3.2, and this is the allowance that we would give on the aortic side for the device's disc to land in. So that would be something around 10 millimeter that we thought as a safe length. And then we went on to make an attempt to measure the distance of the left coronary artery, which is seen over here from the edge of the defect, which was roughly around 7 millimeters. And here we find the gradient of 50 by 20 across the defect, suggesting it was a moderately restrictive AP window. And here again, making further measurements at the pulmonary end as well as the aortic end, and the distance across between the two discs that eventually would be falling in place. So we found that the length would be somewhere around 3.5 millimeter, which meant that we need to use a short length device to sit in perfectly over there to fit in this anatomy. So I did a brief review of literature where I've just mentioned the ones where I could find the age, weight, the device, and the size of defect, but there were many other case reports which I couldn't get all the details of. And so the most frequently used device appeared to be AD02, and then there was one septal occluder, and some had used knit occlude, membranous VSD device, and muscular. Almost everything had been attempted. So coming to our case where the device was to be selected, it was somewhere between 3 to 4 millimeter in size by echocardiography. So we wanted to go in with either a 5 or a 6 sized device. The options that we had, the ASD device, the AD02, the PMVSD device, and the PDA device, which is AD01. So coming on the pros and cons of all these, we wanted a short length of device, the last row depicting it. So PDA device, the typical one, AD01, was a little too lengthy for it to be fitting into this position. So this is almost kind of not a great idea to go on with. Coming on the ASD device, look at the ends, the aortic and the pulmonary end, really big. So what I showed in one of the slides was that 10 millimeter, 12 millimeter was the allowance that we had for the disc to actually sit on the aortic side, and 18 in a 6-month-old baby weighing 5 was a tad little big. And coming on between AD02 and perimembranous, similar aortic ends, similar pulmonary ends, and the best part, both could be delivered from either the venous or the pulmonary end because they were symmetric devices. And the waist was 6 in each, and the length was similar. AD02 slightly longer than the perimembranous VSD device. So the contest was between AD02 and PMVSD, and we kept both on shelf, and we went on the procedure. The strategy was the initial aortic root aims here to determine the distance from the left main coronary artery, which will take us forward or back out from the procedure depending on how far away LMCA was from the defect. And then the initial approach was a trial at crossing from the venous side, and then if unsuccessful, go on to the arterial because it was a very small baby weighing around 5 kgs. There was a risk of losing the femoral pulse from the arterial side, and hence not the best option to go ahead with. And then was the arteriovenous railroad or the arteriovenous loop to be created in case both were not okay. So we had this initial angiogram in an AP view and showing the defect to be far away from the left main origin, and we measured this to be 7.5 millimeters. And there was a good distance between the aortic valve and the defect as well. And the same thing in the lateral view. Here again, we're not able to see the pulmonary artery, pulmonary valve or the main pulmonary artery. The bifurcation is very clearly seen, and this didn't add much information on top of the AP view per se. The cath data, we had a normal RA mean pressure of 6, the RE-ED was 60, the pulmonary pressure was elevated at 60/40, and the mean of 48, slightly more than half the aortic pressure, and the QP/QS was calculated to be 2.4:1. So the initial attempt was the attempt to close from the venous side, and this particular loop could not be avoided no matter what we did. So this loop at the tricuspid valve into the right ventricle was almost inevitable, and we crossed the defect with the wire successfully, but then we couldn't track the catheter, and we could not put in the sheath subsequently. We were successful in putting a glide across the defect, but then the sheath wouldn't track. So we gave up this venous side approach, and again tried crossing the arterial side with some kind of skepticism, because I told you it's going to be a small baby in whom we're going to have a pulse loss if we went ahead, but it was again not successful, and so we finally went on to this, where we did arteriovenous railroad and put the wire in the branch pulmonary artery and snared it through the contralateral venous side. And here we have the pigtail in situ and giving the dye when we finally decided to deploy the device. And the initial attempt at deployment was unsuccessful as the device completely prolapsed out into the pulmonary artery, which I'm not showing over here. And subsequently, we gave this injection to see where we are landing, and then went ahead with the deployment. And we did have echo guidance along with it. And this was the final deployment, where the device landed with a kind of a jump and sitting where it should have. So this is a check angiogram after the device deployment. Again, it's very important to see how far the LMCA was from the device to make sure there's no problem occurring with it. And we found that the device was well far away from the left main coronary artery. And this was after release. The device appeared to be stable. And the echo done immediately after, before the release also showed some kind of impingement of the origin of the right pulmonary artery with a mild gradient of 12. And the same thing was seen in the post-procedure echo, where the device was well away from the pulmonary valve, and there is some impingement of the right pulmonary artery at its origin, and the gradient, as I told you, measured to be 12 to 14. And here we can see the turbulence of the RPA origin. So this was a case. And what did we learn? More than technically, it might not have been a complex case, but we did quite some homework before trying to choose what kind of device might best suit this anatomy. And being a small child, I think that was pretty essential, because we wouldn't want to create a bulk effect either on the aorta or the PA side. And the coronary, again, we didn't have much of a space. 7 millimeter wouldn't mean really a lot, and we had to be pretty careful there not to damage the ostium of the left main coronary artery. So the learning points over here in the initial assessment is very, very important to rule out intra-aortic arch, because we know the common association, and there has been a case report where they went ahead with the procedure and then found that during on-table that the arch was interrupted. And we have to ensure adequate distance from pulmonary valve and left main coronary by echo, and of course confirm by angio before embarking on closing the defect with the device. And direct closure from venous and aortic end may be difficult, as was in our case, but some operators have been successful in doing it so, and it might necessitate a railroad arteriovenous loop that way. And device with short waist would be really good, especially in infants weighing less than 6 kgs and less than 6 months or 1 year of age. And check angio to assess the flow of coronaries after deployment is mandatory. And MPL angio, which we didn't do, would be a good idea to do after the procedure to look at the branch PA status. And echo might be okay for assessment too. So here's our baby who came at 2-month follow-up with some weight gain and the device looking beautiful, the cardiomegaly which regressed. And thank you all for the patient listening.